Thanks for this opportunity. It's really cool to be here. I'm going to present a study which is called Risk Factors for Internalizing Symptoms, the influence of empathy, theory of mind, and active thinking processes. And this has been published in Human Brain Mapping earlier this year. And let's start with the definition of internalizing symptoms first. So in general, we know this term is often used as an umbrella term, including a wide range of different symptoms, including distress, perceived stress, negative affect, depressed mood. And as such, of course, we know all these feelings from ourselves. So it's part of a normal emotional spectrum, but can also be a key feature of a mental disorder when they are, for instance, more pronounced or longer lasting, crossing a specific threshold. And this is why, identifying risk factors for internalizing symptoms, for example, are very important, as they can be a potential target for prevention of mental disorders. And interestingly, next to a lot of other risk factors for internalizing symptoms, one model proposed that empathy and fear of mind might be related to internalizing symptoms. So let's have a closer look at this theoretical model. So why would empathy be linked to internalizing symptoms? As we all know, empathy, theory of mind is super crucial for adequate social interactions, for understanding others. Here we understand empathy as an effective process of sharing others' emotions. We know there are a lot of different definitions out there. Fear of mind, on the other hand, often referred to perspective taking, mentalizing, cognitive empathy, may be more defined as inferring other people's mental states on a cognitive level. So from a dimensional perspective, both processes can have low or high expressions. And for example, when I get easily impacted by other people's feelings and over-empathize, over-mentalize, my feelings may turn into empathic distress, and this in turn is linked to internalizing symptoms. On the other hand, I might be not so good at mentalizing or empathizing, so I am on the lower side maybe, and so this maybe lead more to prediction errors in social interactions, disrupt social interactions, and this in turn can also lead to stress in the context of a social interaction. We know, of course, that these associations are far more complex. So the model also assumes a lot of different moderators. But for example, we focused here on negative thinking processes. And this is why in our study, we were particularly interested in assessing empathy and theory of mind on different levels of measurement, and also including moderators such as negative thinking, rumination, and self-blame in this case, to predict perceived stress and negative affect. And we were also interested in looking at reflective associations, because we thought, how can we capture this, these more extreme levels or this dimensional perspective? To assess this kind of very complex relationships, we used the baseline data from the large longitudinal mental training study, including 302 healthy participants. And we used the interpersonal reactivity index to assess empathic distress and perspective taking. And we also measured behavioral empathy or empathy-related brain activity, and also theory of mind-related brain activity with the Empaton task, which I very briefly introduced to you now. So the participants watched a very short video of a person telling a short personal story that is either neutral or emotional, and that also demands either the ability to use theory of mind to infer about the people's goals, for example, or just a simple factual reasoning. And second, participants are asked to rate how they feel after the video, but also how much compassion they feel for the person in the video. And last, they are asked either a question that demands, again, theory of mind or just simple factual reasoning. And what did we find here? So first, interestingly, we didn't find any quadratic associations of self-report and behavioral level between empathy and internalizing symptoms, as you can see here. No U-shaped whatsoever. But interestingly, we found a positive linear association of self-reported empathic distress and internalizing symptoms. So higher empathic distress, not surprisingly, is associated with internalizing symptoms. In this case, stress and negative affect. On the other hand, we found the opposite. So we found a negative linear association between self-reported theory of mind or perspective taking with stress and negative affect. So lower theory of mind was associated with more stress or negative affect. And now the complex part begins. So interestingly, we did indeed find a quadratic association of empathy-related brain activity in the insula that was moderated by rumination. So try to here. So here you see the insular empathy-related insular activity, and I walk you through this figure because it's quite complex. So you see on the one hand, people who either had lower or higher empathy-related insular activity in combination with higher levels of rumination, described or reported more stress in our study. And why is that? So let's assume I am a very empathetic person, of course, reflected by more insular activity. In combination with a tendency to brood and ruminate a lot about my own feelings, I might feel more stressed. On the other hand, we might speculate that people who are less good in empathizing with others, but also ruminate a lot, they might feel a sort of discrepancy between their own feelings and the feelings of other people in social situations, leading to more stress. And last, we also found quadratic associations of theory of mind-related activity in the middle temporal gyrus that was moderated by rumination and self-blame. This was a bit more complex and also I just teased this, but we can have questions during the discussion or you check out the paper. And in general, we found a complex pattern of results. Amongst others, we found that low theory of mind and high empathic distress on self-report level may be a risk factor for internalizing symptoms. We found these quadratic associations on brain level, but not on behavioral or self-report level. So this might be due to the measures we used. And last, of course, this is a limitation of the study. We only use cross-sectional data. So there's more research needed to assess causal risk factors. But this is a first indication for this complex pattern of relationships. And with that, thanks to a lot of people showing here.